The emergency room at St. Mary's Hospital buzzed with its usual chaos. Fluorescent lights hummed overhead, casting harsh shadows across the waiting area, filled with people nursing various injuries and ailments. The smell of antiseptic mixed with fear and pain created an atmosphere that anyone who had spent time in emergency rooms would recognize instantly. Dr. Marcus Webb adjusted his stethoscope and glanced at the clock on the wall. His 12-hour shift was nearly over, and fatigue weighed heavily on his shoulders. He had been working at St. Mary's for 8 years, and the routine had become second nature. Triage patients, treat the urgent cases, discharge the rest. Simple, efficient, profitable. The automatic doors slid open with a soft whoosh, letting in the cool evening air along with a woman who immediately caught the attention of everyone in the waiting room. She walked with a slight limp, favoring her right leg, and her left arm hung at an odd angle against her body. Her clothes were torn and dirty, suggesting she had been in some kind of accident or altercation. What struck people most, however, was not her obvious injuries, but her demeanor. Despite the pain she must have been experiencing, she moved with a quiet confidence that seemed almost out of place in the chaotic environment of the emergency room. Her dark hair was pulled back in a simple ponytail, and though her face was pale with pain, her eyes remained alert and focused. She approached the reception desk where Nancy Peterson, a veteran nurse with 25 years of experience, was processing paperwork from the previous patient. Nancy looked up with the practiced smile she reserved for new arrivals, though her expression quickly shifted to one of concern as she took in the woman's condition. "Good evening," the woman said, her voice steady despite the obvious discomfort. "I need medical attention. I believe I have a dislocated shoulder and possibly a fractured tibia." Nancy's eyebrows rose slightly. Most patients who came through these doors described their pain in general terms, complaining of hurting all over or being unable to specify exactly what was wrong. This woman spoke with the precision of someone who had medical training or, at the very least, extensive experience with injuries. "Of course, honey," Nancy replied, reaching for the standard intake forms. "Let me get you registered. Do you have insurance?" The woman reached into her jacket pocket with her good arm and produced a wallet. As she fumbled to extract her insurance card, Nancy noticed something that made her pause. The woman's hands, despite the obvious pain she was experiencing, remained remarkably steady. There was no trembling, no visible signs of shock that typically accompanied serious injuries. "Here's my insurance card," the woman said, handing over a standard blue and white card. "And my identification." Nancy glanced at the cards, noting the name, Sarah Michelle Torres. The address listed was local, and the insurance appeared to be standard civilian coverage. Nothing unusual there. She began entering the information into the computer system, her fingers moving automatically across the keyboard. "What happened to you, dear?" Nancy asked, continuing to type without looking up. "Training accident," Sarah replied simply. "I was participating in an obstacle course exercise and took a fall." Nancy nodded absently. The hospital saw plenty of people injured during various fitness activities, from weekend warriors overdoing it at the gym to amateur athletes pushing beyond their limits. She had heard every variation of training accident imaginable. "Any allergies to medications?" Nancy asked, continuing down her standard list of questions. "None." "Previous surgeries or medical conditions?" "None." "Emergency contact?" Sarah provided a name and phone number, which Nancy dutifully entered into the system. The process was routine, mechanical, something both women had done countless times before in their respective roles. Dr. Webb emerged from one of the examination rooms, having just finished treating a teenager who had cut his hand while working on his motorcycle. He glanced at the waiting room, noting the usual collection of patients in various stages of distress, and his eyes briefly settled on Sarah. From his perspective, she looked like any other person who had gotten themselves hurt doing something they probably should not have been doing. Her clothes suggested outdoor activity, and the injuries she described to Nancy were consistent with someone who had been hiking or engaging in some form of recreational exercise that had gone wrong. "Room 3 is ready," Dr. Webb called to Nancy, indicating that Sarah could be taken back for examination. Nancy stood up from behind the reception desk and gestured for Sarah to follow her. "Right this way, honey." As they walked toward the examination room, Nancy noticed that despite her limp, Sarah moved with an economy of motion that suggested someone accustomed to physical activity. She did not lean heavily on the walls for support or ask for assistance, and she stepped carefully but confidently across the polished hospital floor. The examination room was small and sterile, equipped with the standard medical furniture and supplies found in any emergency room. Nancy helped Sarah onto the examination table, noting how she positioned herself to minimize discomfort while maintaining her alert posture. "The doctor will be with you shortly," Nancy said, making notes in Sarah's chart. "Is the pain manageable right now?" "It's tolerable," Sarah replied, a response that surprised Nancy. Most patients with visible injuries like Sarah's would be asking for pain medication immediately, describing their discomfort in dramatic terms. This woman seemed almost dismissive of what had to be significant pain. Nancy left the room, and Sarah found herself alone with her thoughts for the first time since the accident. The obstacle course had been more challenging than usual, designed to push even experienced participants to their limits. The final wall climb had required techniques that she had mastered years ago, but a loose handhold had given way at the worst possible moment. The fall itself had been textbook. She had rolled with the impact, distributing the force across her body rather than absorbing it all in one spot. The techniques that had been drilled into her countless times had probably prevented much more serious injury. Still, she had felt the shoulder separate and heard the distinct crack that suggested bone damage in her leg. What frustrated her more than the pain was the timing. She was scheduled to deploy in 3 weeks, and this injury would almost certainly delay those plans. Her team was counting on her, and she prided herself on never letting her teammates down. Physical setbacks were part of the job, but that did not make them any easier to accept. Dr. Webb appeared in the doorway, chart in hand, and the slightly impatient expression that often accompanied the end of a long shift. He glanced at Sarah's information as he entered the room, noting the mechanism of injury and the initial assessment Nancy had recorded. "Ms. Torres," he said, settling onto the small stool next to the examination table. "I understand you had a training accident. Can you tell me exactly what happened?" Sarah described the fall in clear, precise terms, explaining how she had lost her grip on the climbing wall and fallen approximately 12 feet onto a combination of sand and rubber matting. She detailed the position she had landed in and the immediate pain she had felt in her shoulder and leg. Dr. Webb listened with half his attention, already forming his treatment plan based on what appeared to be a straightforward case. Young woman, probably a fitness enthusiast, had pushed herself too hard and gotten hurt. He had seen dozens of similar cases. "Let's take a look at that shoulder," he said, moving to examine the injured area. As he gently manipulated Sarah's arm, Dr. Webb was struck by her lack of reaction to what should have been quite painful. Most patients would have winced, pulled away, or at least shown some facial expression indicating discomfort. Sarah remained completely still, her breathing steady and controlled. "That doesn't hurt?" he asked, applying pressure to the area where he suspected the dislocation had occurred. "It hurts," Sarah replied matter-of-factly, "but it's manageable." Dr. Webb frowned slightly. In his experience, people who claimed serious injuries were manageable were either exaggerating their symptoms for attention or were under the influence of something that was masking their pain. Sarah showed no signs of intoxication or drug use, which left the possibility that she was simply being overly dramatic about relatively minor injuries. He continued his examination, checking the range of motion in her shoulder and palpating the area around her leg where she claimed to have suffered a fracture. His touch was not particularly gentle. After 8 years in emergency medicine, he had developed a somewhat mechanical approach to patient care that prioritized efficiency over bedside manner. "I'm going to need X-rays to confirm any fractures," he said, making notes in her chart. "The shoulder feels like a minor subluxation rather than a true dislocation. You'll probably need some physical therapy and rest." Sarah's eyebrows rose slightly. She had dislocated her shoulder twice before during training exercises, and she was quite familiar with what the injury felt like. This was definitely a full dislocation, not the partial separation that Dr. Webb was suggesting. "Doctor," she said carefully, "I'm fairly certain this is a complete dislocation. I've had this injury before, and I'm familiar with the symptoms. Dr. Webb looked up from his chart, and Sarah caught a flash of irritation in his eyes. He clearly did not appreciate patients who attempted to diagnose themselves or question his professional assessment. Ms. Torres, he said, his tone becoming slightly condescending. I understand that you might think you know what's wrong, but I've been practicing medicine for 8 years. Let me do my job, and we'll get you taken care of. The dismissive tone might have offended or intimidated other patients, but Sarah simply nodded and remained quiet. She had learned long ago that some battles were not worth fighting, especially when she needed medical care. Still, she made a mental note of the doctor's attitude and his apparent unwillingness to listen to her input about her own body. Dr. Webb ordered x-rays for both her shoulder and her leg, and Nancy returned to escort Sarah to the radiology department. The trip down the hallway gave Sarah another opportunity to observe the hospital's operations, and she found herself automatically noting details about security, staffing levels, and emergency procedures, habits that had become second nature in her profession. The radiology technician was a middle-aged man named Jim who had worked at the hospital for 15 years. He positioned Sarah carefully for the x-rays, and she followed his instructions precisely, moving her body into the required positions despite the obvious discomfort. "You're a good patient," Jim commented as he prepared for the final image. "Most people with injuries like yours are much more difficult to position." "Thank you," Sarah replied simply, though she wondered what Jim would think if he knew that she had been trained to function effectively even when seriously wounded. The pain she was experiencing now was nothing compared to some of the challenges she had faced during her career. The x-rays took about 20 minutes to complete, and then Sarah was escorted back to the examination room to wait for the results. The hospital's policy required that a radiologist review all emergency room x-rays before they were released to the attending physician, which typically added another 30 to 45 minutes to the process. During this waiting period, Sarah had time to observe more of the hospital's operations. She could hear conversations from adjacent rooms, the movement of staff in the hallway, and the general rhythm of an emergency department dealing with its evening patient load. The sounds were familiar to anyone who had spent time in medical facilities, but Sarah processed them with the heightened awareness that her training had developed. Dr. Webb appeared in her room again about an hour later, carrying printed copies of her x-rays and wearing an expression that suggested he had been hoping for different results. He clipped the images to the light board on the wall and studied them for a moment before turning to address Sarah. "Well," he said, his tone notably less confident than it had been earlier, "it appears you were right about the shoulder. It is completely dislocated, and there does appear to be a hairline fracture in your tibia." Sarah nodded, but said nothing. She had known the severity of her injuries from the moment they occurred, but pointing that out now would serve no useful purpose. "The shoulder will need to be reduced, put back into place," Dr. Webb continued, "and the leg fracture will require immobilization in a cast or walking boot. Given the extent of these injuries, I'm curious about this training accident you mentioned. What type of training involves a 12-foot fall?" For the first time since arriving at the hospital, Sarah hesitated before answering. The question touched on areas that she could not discuss in detail, and she needed to provide an explanation that was both truthful and appropriately vague. "I participate in advanced fitness programs," she said finally. The obstacle course was designed to be challenging. Dr. Webb studied her for a moment, clearly sensing that there was more to the story than she was sharing. However, patients were not required to provide detailed explanations of how they had been injured, and he had more pressing concerns than satisfying his curiosity. "I'll need to reduce the shoulder dislocation before we can proceed with treatment for the leg," he explained. "This is going to be quite painful, even with local anesthesia. I can provide you with some pain medication before we begin." "That won't be necessary," Sarah replied. "I can handle it." Dr. Webb stared at her in disbelief. Shoulder reductions were among the most painful procedures performed in emergency rooms, and even patients who claimed high pain tolerance typically requested some form of medication before the process began. "Ms. Torres," he said slowly, "I don't think you understand how painful this procedure is going to be. We're essentially going to manipulate your arm to force the joint back into its proper position. Most patients require significant pain relief." "I understand," Sarah said calmly. Please proceed with the reduction. Dr. Webb shook his head, but did not argue further. If the patient wanted to experience unnecessary pain, that was her choice. He called for Nancy to assist with the procedure and began preparing the equipment he would need. Nancy entered the room carrying supplies and immediately noticed the tension in the air. "Is everything all right?" she asked, glancing between Dr. Webb and Sarah. "Ms. Torres has declined pain medication for the shoulder reduction," Dr. Webb explained, his tone suggesting that he thought the decision was foolish. Nancy's eyebrows rose, but she had seen enough unusual patient requests over the years that she simply nodded and began setting up the equipment. She positioned herself to help hold Sarah steady during the procedure and gave her a reassuring smile. "This is going to hurt," Nancy warned gently. "Are you sure you don't want something for the pain?" "I'm sure," Sarah replied, positioning herself as Dr. Webb had instructed and preparing mentally for what was to come. Dr. Webb began the reduction procedure, applying steady pressure to manipulate Sarah's arm back into its proper position. The process required significant force and precise movement, and he expected Sarah to cry out, pull away, or at least show some visible sign of distress. Instead, she remained perfectly still, her breathing controlled and her face calm. Her only reaction was a slight tightening around her eyes when Dr. Webb applied the most pressure, and even that was barely noticeable. The next phase of Sarah's treatment involved addressing the hairline fracture in her tibia. Dr. Webb had expected that dealing with the leg injury would be more straightforward than the shoulder dislocation, but Sarah's unusual behavior during the previous procedure had left him feeling uncertain about his patient. Nancy helped Sarah move from the examination table to a wheelchair for transport to the orthopedic clinic within the hospital. The fracture would require specialized attention, and Dr. Webb wanted a second opinion before proceeding with treatment. As they moved through the corridors, Nancy found herself studying Sarah more carefully than she normally would observe a patient. "Have you been injured like this before?" Nancy asked as they waited for the elevator. "A few times," Sarah replied, which was technically true. During her career, she had sustained numerous injuries ranging from minor cuts and bruises to more serious trauma. The current injuries were actually relatively minor compared to some she had experienced during combat operations. The orthopedic clinic was located on the third floor of the hospital, and Dr. Rebecca Chun, the on-call orthopedic surgeon, was waiting for them when they arrived. Dr. Chun had a reputation for thoroughness and attention to detail, qualities that had made her one of the most respected specialists at St. Mary's Hospital. "Ms. Torres," Dr. Chun said, reviewing the x-rays that had been sent ahead electronically. "I understand you have a tibial fracture from a training accident. Can you walk on the leg at all?" Sarah demonstrated her ability to bear weight on the injured leg, though she clearly favored it, and walked with a noticeable limp. Dr. Chin watched her movement patterns carefully, noting the controlled way Sarah managed her discomfort and the efficient manner in which she compensated for the injury. "The fracture is relatively minor," Dr. Chin explained, pointing to the crack visible on the X-ray. "It should heal well with proper immobilization. However, I'm curious about the mechanism of injury. A 12-foot fall that results in this specific type of fracture pattern usually indicates that the person had some training in how to fall safely." Sarah nodded, but did not elaborate, and Dr. Chin did not press for additional details. Instead, she focused on explaining the treatment plan, which would involve wearing a walking boot for 6 to 8 weeks followed by physical therapy to restore full strength and mobility. "Given the nature of your other injury," Dr. Chin continued, "I assume you're involved in some type of serious athletic training. What sport or activity were you participating in when this happened?" "Obstacle course training," Sarah replied, keeping her answer as general as possible. Dr. Chun made notes in Sarah's chart while considering the implications of the injuries and the patient's responses. The combination of a shoulder dislocation and tibial fracture from a controlled fall suggested someone with significant physical training and experience with dangerous activities. The patient's pain tolerance and calm demeanor further supported that impression. "I'll need to fit you with a walking boot," Dr. Chin said. "The injury should heal completely, but it's important that you follow the weight-bearing restrictions I'm going to give you. No running, jumping, or other high-impact activities for at least 6 weeks." Sarah's expression tightened slightly at the mention of activity restrictions. 6 weeks would definitely interfere with her deployment schedule, and she would need to notify her commanding officer about the medical limitations as soon as possible. Is there any way to accelerate the healing process? Sarah asked. I have professional obligations that make extended downtime problematic. Dr. Chen paused, considering the question. Most patients were eager to avoid activity during recovery, happy to have an excuse to rest. This patient seemed genuinely concerned about missing work or training, which was another unusual element in an already atypical case. I'm afraid not, Dr. Chen replied. Bone healing takes time, and pushing too hard too early can result in re-injury or complications that would keep you out of action much longer than 6 weeks. While Dr. Chen prepared the walking boot, Nancy continued her observations of Sarah. During her years in nursing, she had developed an intuitive sense about patients, and something about this woman did not fit the typical patterns she was accustomed to seeing. Most people who came to the emergency room with serious injuries displayed obvious signs of stress, anxiety, or pain. They asked numerous questions about their prognosis, worried about the costs of treatment, or showed other normal human reactions to unexpected medical problems. Sarah displayed none of these behaviors. Instead, she seemed to be processing the information about her injuries and treatment with the methodical approach of someone accustomed to dealing with adverse circumstances. She asked practical questions about recovery time and activity restrictions, but she showed no emotional distress about her situation. Have you ever been in the military? Nancy asked casually as Dr. Chen worked on fitting the walking boot. Sarah looked up sharply, and for a moment her carefully controlled expression showed a flicker of surprise. What makes you ask that? Just the way you handle pain and stress, Nancy replied. My brother was in the Army, and he had that same calm way of dealing with injuries. I've done some training with military-style fitness programs, Sarah said, which was true in a technical sense, though it vastly understated her actual background. Nancy nodded and did not pursue the subject further, but she filed away Sarah's reaction for future consideration. In her experience, people who had military backgrounds often tried to downplay that fact when they were seeking medical care, sometimes because they were concerned about how they would be perceived or treated. Dr. Chen finished adjusting the walking boot and tested Sarah's ability to walk with the device. This should provide the support and immobilization your leg needs while still allowing you to remain mobile, she explained. You'll need to wear it constantly for the first 4 weeks. Then, we can reassess your progress. Sarah stood and tested the boot, automatically adjusting her gait to accommodate the device. Her adaptation was immediate and efficient, suggesting someone accustomed to operating with equipment or under physical limitations. Do you have any questions about the care instructions? Dr. Chen asked, handing Sarah a printed sheet with detailed information about managing the injury. Sarah scanned the document quickly, absorbing the information with the focused attention of someone trained to process important instructions rapidly and accurately. This is clear, she said. Thank you. As they prepared to return to the emergency room to complete the discharge process, Dr. Chen pulled Nancy aside for a brief private conversation. Has this patient seemed unusual to you? Dr. Chen asked quietly. Very much so, Nancy replied. I've never seen anyone handle pain the way she does. And she speaks about her injuries with medical precision that most people don't have. I agree, Dr. Chen said. Her responses and behavior suggest someone with extensive training in dealing with trauma. The injuries themselves are also consistent with someone who knows how to fall safely but still got hurt due to equipment failure or unexpected circumstances. Nancy considered this observation. Do you think she's law enforcement or military? It's possible, Dr. Chen replied. But if so, she's not talking about it. That could mean she's involved in something sensitive or classified. The two medical professionals had encountered patients before who were reluctant to discuss their backgrounds, particularly those involved in law enforcement, military service, or other occupations that required discretion about their activities. They had learned to provide excellent medical care without prying into areas that patients preferred to keep private. Back in the emergency room, Dr. Webb was completing Sarah's discharge paperwork and preparing to release her from the hospital. The successful treatment of her injuries had restored his confidence in his medical skills, though he remained puzzled by her unusual responses during treatment. "Ms. Torres," he said as Nancy wheeled her back into the examination room, "your shoulder reduction was successful, and Dr. Chun has addressed the leg fracture. You'll need to follow up with your primary care physician in 1 week and with orthopedics in 2 weeks." Sarah accepted the discharge instructions and follow-up appointment information, scanning the documents with the same focused attention she had shown throughout her visit. Dr. Webb noticed that she read everything completely rather than simply accepting the paperwork, as most patients did. "Do you have transportation home?" Nancy asked, following standard discharge protocol. "I'll call someone," Sarah replied, reaching for her phone. As Sarah made her phone call, Nancy and Dr. Webb stepped outside the room to discuss the case privately. Both had been struck by the patient's unusual characteristics, and they wanted to compare their observations. "In 8 years of emergency medicine, I've never seen anyone tolerate a shoulder reduction like that," Dr. Webb said. "And her knowledge of her own injuries was remarkably precise. She seems like someone with extensive medical or trauma training," Nancy agreed. "Her whole demeanor suggests military or law enforcement background, but she's not admitting to anything specific." Dr. Webb nodded thoughtfully. "Maybe she's a paramedic or EMT. That would explain the medical knowledge and the pain tolerance." "Possibly," Nancy said, though she was not entirely convinced by that explanation. "But there's something else about her that seems more intense than what I'd expect from standard emergency medical training." Their conversation was interrupted by Sarah's appearance in the doorway. She had completed her phone call and was ready to leave the hospital. Moving carefully but steadily on her walking boot, she approached the nurse's station to complete the final discharge procedures. "Someone will be here to pick me up in about 20 minutes, Sarah informed them. "Is there anything else I need to do before leaving?" Dr. Webb handed her the final paperwork, including prescriptions for pain medication and instructions for caring for both injuries at home. "The pain medication is important," he emphasized. "Don't try to tough this out unnecessarily." Sarah accepted the prescription, but privately doubted she would fill it. Her training had taught her to avoid medications that might impair her judgment or reaction time unless absolutely necessary. And the current level of pain was definitely manageable without pharmaceutical intervention. "Thank you for your care," Sarah said, shaking hands with both Dr. Webb and Nancy. Her grip was firm and confident, another small detail that reinforced their impressions about her background. As Sarah made her way to the hospital's main entrance to wait for her ride, Nancy found herself watching through the window. Even with the walking boot and her injured shoulder, the woman moved with a purposefulness and awareness that was distinctly different from typical patients. "I wish I knew what her real story was," Nancy said to Dr. Webb as they watched Sarah settle into a chair near the entrance. "Some people prefer their privacy," Dr. Webb replied, though he shared Nancy's curiosity. "As long as we provided good medical care, that's what matters." Outside, Sarah sat quietly and used the waiting time to make another phone call, this one to her commanding officer to report the injury and discuss how it might affect her upcoming deployment. The conversation was brief and professional, focusing on the medical facts and timeline for recovery. "How bad is it?" her commanding officer asked. 6 to 8 weeks for full recovery," Sarah reported. "I can maintain some level of training with modifications, but nothing high impact for at least a month." "Roger that. We'll adjust the deployment schedule accordingly. Take care of yourself, Torres." "Will do, sir. Thank you." The phone call reminded Sarah of one of the things she valued most about military service: the straightforward, practical approach to problem solving. Injuries happened, schedules were adjusted, and everyone moved forward without unnecessary drama or complications. A dark sedan pulled up to the hospital entrance, and Sarah recognized her teammate, Mike Peterson, behind the wheel. She gathered her paperwork and carefully made her way to the vehicle, accepting Mike's assistance in getting settled in the passenger seat. "How did it go in there?" Mike asked as they drove away from the hospital. "Standard emergency room experience," Sarah replied. "The staff was competent, though they seemed curious about my background." "Did you tell them anything?" "Nothing beyond the basic facts about the training accident. They provided good medical care without needing my life story." 3 days after her discharge from St. Mary's Hospital, Sarah Torres was adjusting to life with a walking boot and a healing shoulder when her phone rang with news that would change everything about her recent hospital experience. Torres, this is Commander Patricia Walsh from Naval Special Warfare Group 2, the voice on the other end said. We need to discuss your recent medical treatment. Can you come in today? Sarah's stomach tightened. Commander Walsh was not her direct superior, and her involvement suggested that Sarah's hospital visit had somehow attracted official attention. Yes, ma'am. Is there a problem? We'll discuss it when you get here. Report to my office at 1400 hours. The line went dead, leaving Sarah to wonder what could have gone wrong. She had been careful not to reveal any classified information during her hospital stay, and her injury had occurred during routine training rather than operational activity. Still, the formal tone of the conversation suggested serious concerns at higher levels of the command structure. Sarah arrived at the Naval Special Warfare Facility early, using the extra time to review mentally everything that had happened during her hospital visit. She could not identify anything she had said or done that might have compromised security or violated regulations, but Commander Walsh's call had been ominous enough to warrant careful preparation. Commander Walsh's office was spartanly decorated with the standard military efficiency that characterized most spaces in the facility. Walsh herself was a stern woman in her mid-40s who had earned respect through competence and demanding standards rather than popularity or charm. Sit down, Torres, Commander Walsh said without preamble. We need to talk about your visit to St. Mary's Hospital 3 days ago. Yes, ma'am, Sarah replied, taking the offered seat and waiting for the commander to explain the purpose of the meeting. Did you know that Dr. Marcus Webb, the physician who treated you, is married to Captain Jennifer Webb of the Marine Corps? Commander Walsh asked. Sarah felt her confusion deepen. No, ma'am. He never mentioned his wife, and I saw no reason to inquire about his family. Captain Webb is currently serving as a military intelligence analyst, Commander Walsh continued. She specializes in identifying and assessing security risks, particularly those involving personnel with specialized training or security clearances. The implications of this information began to sink in as Sarah realized where the conversation was heading. She became suspicious about my background. More than suspicious, Commander Walsh replied. Dr. Webb described your behavior and responses during treatment to his wife, and she immediately recognized patterns consistent with advanced military training. She initiated an investigation into your background. Sarah's mind raced as she considered the ramifications. Her cover identity had been carefully constructed to withstand routine scrutiny, but a determined investigation by military intelligence could potentially expose her real assignment and compromise ongoing operations. What did the investigation reveal? Sarah asked. That's what makes this situation complicated, Commander Walsh said, leaning back in her chair. Your cover identity is excellent, probably too excellent. Captain Webb's investigation hit walls that are only in place for personnel involved in highly classified operations. Commander Walsh opened a folder on her desk and consulted several documents before continuing. The investigation triggered security protocols that brought your case to the attention of people much higher up the chain of command than either of us. Sarah remained silent, understanding that the situation had escalated far beyond a simple medical visit. The careful operational security that protected special operations personnel had been designed to prevent exactly this type of exposure, but it had also created its own set of problems. The good news, Commander Walsh continued, is that Captain Webb is a professional intelligence officer who understands the importance of maintaining security for classified operations. The bad news is that your cover identity may now be compromised for future use. What are the recommendations? Sarah asked. That depends on several factors that are above my pay grade, Commander Walsh replied. But, for now, you're going to have a visitor who wants to discuss your hospital experience in detail. A knock on the office door interrupted their conversation, and Commander Walsh called for the person to enter. A woman in Marine Corps uniform stepped into the room, and Sarah immediately recognized her as someone who shared certain physical characteristics with Dr. Webb. Torres, this is Captain Jennifer Webb, Commander Walsh said. Captain Webb, this is Petty Officer Torres. Captain Webb was an attractive woman in her early 40s with intelligent eyes that seemed to catalog every detail of Sarah's appearance and demeanor. She moved with the confident bearing of someone accustomed to command responsibility and serious decision-making. Petty Officer Torres, Captain Webb said, offering her hand in greeting. I apologize for any complications my investigation may have caused. Sarah stood and shook the offered hand, noting the firm grip and direct eye contact that characterized most military professionals. No apology necessary, ma'am. You were doing your job. Indeed I was, Captain Webb replied. And, based on what my husband described about your behavior during treatment, I believe you were doing yours as well, even while injured and seeking medical care. Captain Webb settled into a chair across from Sarah while Commander Walsh observed the interaction. My husband was quite impressed by your pain tolerance and your knowledge of your own injuries. He's treated thousands of patients over the years, but very few have demonstrated the level of self-control you showed during that shoulder reduction. I've had training in dealing with pain and stress, Sarah replied carefully. So I gathered, Captain Webb said with a slight smile. The question is what kind of training and why someone with your level of capability was seeking treatment at a civilian hospital rather than using military medical facilities. Sarah glanced at Commander Walsh, who nodded to indicate that she should answer honestly. I was participating in off-base training activities. The injury occurred after normal duty hours, and the civilian hospital was closer than the base medical facility. Captain Webb made notes on a small pad as Sarah spoke. My investigation into your background revealed several interesting facts. Your service record shows appropriate training and qualifications, but certain details are classified at levels that suggest involvement in special operations. I can't discuss specifics of my assignments, Sarah said. I understand, Captain Webb replied. But I can discuss my husband's observations, which paint a picture of someone with training that goes far beyond standard military preparation. Captain Webb consulted her notes before continuing. Marcus described your behavior as remarkably controlled and professional. You diagnosed your own injuries with medical precision, tolerated extremely painful procedures without medication, and showed none of the emotional stress responses that characterize most emergency room patients. Sarah listened carefully, understanding that Captain Webb was building towards some specific conclusion about her background and capabilities. More importantly, Captain Webb continued, you maintained perfect operational security throughout your treatment. You provided only the minimum information necessary for medical care, kept your personal history appropriately vague, and avoided any statements that might have revealed classified information. Those are basic security practices, Sarah said. For someone in your line of work, yes, Captain Webb agreed. But not for the average service member, and certainly not for civilian patients. My husband has never encountered anyone who maintained that level of discipline while dealing with serious injuries and pain. Commander Walsh interjected at this point. Captain Webb's concerns are legitimate, Torres. Your behavior during medical treatment was professional and appropriate, but it also marked you as someone with specialized training that could draw unwanted attention. Sarah nodded, understanding the dilemma. Her training had taught her to maintain operational security in all circumstances, but that same training had made her stand out in a civilian medical environment where most patients behaved very differently. What are your recommendations? Sarah asked Captain Webb. Several things, Captain Webb replied. First, your cover identity may need to be adjusted or replaced if you're going to continue operating in civilian environments. Second, you might benefit from training in how to blend more effectively with civilian populations during medical or other emergency situations. Captain Webb paused to review her notes again. Third, and most importantly, we need to ensure that my investigation hasn't compromised any ongoing operations or put other personnel at risk. Commander Walsh took over the conversation. The security review is already underway. Preliminary indications are that no operations have been compromised, but we're being thorough. What about Dr. Webb and the other hospital staff? Sarah asked. Do they pose any ongoing security concerns? My husband is unaware of my investigation, Captain Webb replied. As far as he knows, you were an unusually tough patient with some kind of military or law enforcement background. He's mentioned you a couple of times, but only in terms of your remarkable pain tolerance. Captain Webb smiled slightly. Marcus has actually been telling the story to his colleagues as an example of how people can surprise you. He's impressed by your toughness, but he has no idea about your real background. And the other hospital staff? The nurse, Nancy Peterson, has military family connections, so she recognized some of your behavior patterns, Captain Webb explained. But her observations were general rather than specific, and she hasn't pursued the matter beyond casual curiosity. Commander Walsh concluded the briefing by explaining the next steps in the security review process. You'll be temporarily assigned to desk duties until the review is complete. Your next deployment has been postponed pending resolution of these issues. Sarah accepted the news with outward calm, though she was disappointed about the deployment delay. Her team was counting on her participation in the upcoming operation, and any disruption to the schedule could affect the success of the mission. How long is the review expected to take? She asked. 2 to 3 weeks, Commander Walsh replied. Possibly longer if complications arise. As the meeting concluded, Captain Webb offered some final observations about the situation. Petty Officer Torres, your professionalism during this entire incident has been exemplary. The security concerns are procedural rather than personal, and I want you to understand that no one questions your judgment or actions. Thank you, ma'am, Sarah replied. However, Captain Webb continued, this incident illustrates the challenges of maintaining security while operating in civilian environments. Even routine activities like seeking medical care can create exposure risks that we need to better understand and manage. After Captain Webb left, Commander Walsh dismissed Sarah with instructions to report for desk duty the following morning. As she drove away from the naval facility, Sarah reflected on how a simple training accident had created complications that reached far beyond her individual situation. The irony was not lost on her that her professional competence and training had created the very problems she now faced. The skills that made her effective in her specialized role had also made her conspicuous in a civilian medical environment, drawing exactly the kind of attention that special operations personnel were trained to avoid. That evening, Sarah called her teammate Mike Peterson to update him on the situation. The deployment is postponed indefinitely, she told him. Security review related to my hospital visit. How bad is it? Mike asked. Could be worse, Sarah replied. No operational security was actually breached, but my behavior apparently raised flags with someone who knew what to look for. Lesson learned. Several of them, Sarah said. Next time I get hurt, I'm going straight to the base medical facility regardless of convenience or proximity. Mike chuckled. Or maybe we need better training in how to act like normal people when we're injured. That might actually be a good idea, Sarah agreed. Turns out they're 2 weeks into the security review process. Sarah Torres was settling into the unfamiliar routine of desk duty when her situation took an unexpected turn. The administrative work was keeping her busy, but it was a far cry from the physical and mental challenges she was accustomed to facing in her regular assignments. Commander Walsh called her into the office again on a Tuesday morning, and this time her expression suggested more positive news than their previous meeting had contained. Torres, the security review has been completed, Commander Walsh announced. The good news is that no operational security was compromised, and your actions throughout the entire incident were deemed exemplary. Sarah felt relief wash over her, though she kept her expression neutral. Thank you, ma'am. What about my deployment status? That's where things get interesting, Commander Walsh replied, settling back in her chair with what might have been a slight smile. Your case has attracted attention from some very senior people who are impressed by how you handled a difficult situation. Sarah waited for the commander to continue, uncertain whether this attention was positive or problematic. Admiral Richardson, who oversees special operations training programs, wants to meet with you, Commander Walsh explained. Apparently, your hospital experience has given him ideas about improving our personnel preparation for civilian interactions. This was not the outcome Sarah had expected. When does the Admiral want to meet? This afternoon. He's flying in specifically to discuss your case and its implications for future training programs. The meeting with Admiral Richardson was scheduled for 1400 hours in the base conference room, and Sarah spent the intervening time wondering what the Admiral might want to discuss. Her hospital visit had been routine from her perspective, but it had apparently provided insights that senior leadership found valuable. Admiral Richardson was a distinguished man in his late 50s with silver hair and the bearing of someone accustomed to significant responsibility. He had risen through the ranks by making tough decisions and implementing effective solutions to complex problems. Petty Officer Torres, Admiral Richardson said as she entered the conference room. Please, have a seat. I've been looking forward to this conversation. Sarah took the offered chair across from the Admiral, noting that Commander Walsh was also present along with Captain Webb and another officer she did not recognize. This is Captain Michael Stevens from the Training and Doctrine Command, Admiral Richardson said, introducing the unknown officer. He's here because we're considering some significant changes to our training programs based on what we've learned from your recent experience. Captain Stevens was a lean man with intelligent eyes who took extensive notes as the conversation proceeded. His presence suggested that this meeting had implications beyond Sarah's individual case. Let me start by saying that your conduct throughout this entire incident has been exemplary, Admiral Richardson began. You maintained perfect operational security, demonstrated remarkable professionalism under stress, and handled a potentially compromising situation with exactly the right balance of disclosure and discretion. Thank you, sir, Sarah replied. However, Admiral Richardson continued, your case has also revealed some significant gaps in our training programs that we need to address. You did everything right, but the fact that you stood out so dramatically in a civilian medical environment suggests that we're not adequately preparing our personnel for routine interactions outside military contexts. Captain Stevens spoke up at this point. Could you describe your thought process during the hospital visit? What were you thinking about as you interacted with the medical staff? Sarah considered the question carefully. I was focused on getting appropriate medical care while maintaining operational security. I tried to provide only the information necessary for treatment while avoiding any details about my background or assignment. And your approach to managing pain during the procedures? I used techniques I learned during training to maintain control and avoid showing weakness or vulnerability, Sarah replied. Admiral Richardson exchanged glances with Captain Stevens before continuing. That's exactly what we expected you to do, and it was the right approach from a security perspective. But it also marked you as someone with specialized training that drew investigative attention. The question we're grappling with, Admiral Richardson said, is whether we need to modify our training to help personnel blend more effectively in civilian environments, or whether the current approach is appropriate, and we simply need to accept that some exposure risk is inherent in the work we do. Captain Stevens consulted his notes. Dr. Webb's observations suggest that certain behaviors are immediately recognizable to people with military or law enforcement backgrounds. Your pain tolerance, self-diagnosis capabilities, and controlled responses under stress all indicated advanced training to anyone who knew what to look for. Which raises an interesting point, Captain Webb interjected. In this case, the exposure came not from the general medical staff, but from someone with intelligence training who recognized the significance of behaviors that others might simply find unusual. Admiral Richardson nodded. That's a crucial distinction. The average civilian observer might notice that you're tough or well-disciplined, but it takes someone with specific knowledge to recognize advanced military training. So the question becomes, Admiral Richardson continued, how do we prepare our personnel to interact with both general civilian populations and with individuals who might have the expertise to recognize their backgrounds? Sarah found herself drawn into the strategic discussion. Sir, would it be possible to develop different approaches for different types of civilian interactions? Basic blending techniques for routine situations, and more sophisticated cover protocols for higher-risk encounters. That's exactly the kind of thinking we're looking for, Captain Stevens said, making more notes. What would those different approaches look like in practice? Sarah thought for a moment before responding. For routine medical care, we might need training in how to display more typical stress responses and pain reactions. For situations where security is a higher concern, we would maintain current protocols, but with better preparation for managing the increased scrutiny that might result. Admiral Richardson leaned forward, clearly interested in Sarah's analysis. Give me a specific example of how you might handle a similar medical situation differently. In the emergency room, I could have shown more visible discomfort during the examination, asked more questions about the prognosis and treatment options, and perhaps displayed some anxiety about missing work or other normal concerns, Sarah said. Those behaviors would have been more typical for civilian patients. But would they have interfered with the quality of your medical care? Captain Webb asked. Not significantly, Sarah replied. The medical staff needed accurate information about my symptoms and injury history, but they didn't need me to be stoic about pain or completely calm during procedures. Captain Stevens was writing rapidly, so you could have maintained medical honesty while displaying more typical emotional responses to pain and stress. Exactly, Sarah confirmed. The challenge would be knowing when to use which approach, and being able to switch between them as circumstances required. Admiral Richardson sat back in his chair, clearly processing the implications of the discussion. This suggests that we need to expand our training programs to include what we might call civilian interaction protocols, systematic approaches to blending in during routine activities outside military contexts. The training would need to cover a range of scenarios, Captain Stevens added. Medical emergencies, interactions with law enforcement, routine business transactions, social situations. Anywhere our personnel might need to avoid drawing attention to their specialized backgrounds. Commander Walsh, who had been listening to the discussion, offered her perspective. The challenge would be ensuring that this training doesn't interfere with the operational skills and mindset that make our personnel effective in their primary roles. Agreed, Admiral Richardson said. We can't have people hesitating or second-guessing themselves in combat situations because they're worried about civilian interaction protocols. Sarah offered another observation. The training might be more effective if it focused on conscious choice-making rather than automatic responses, teaching people to recognize when they need to blend in versus when they need to maintain full operational readiness. Explain that concept, Admiral Richardson requested. In the hospital, I could have consciously chosen to display more typical patient behaviors while still maintaining awareness and security consciousness, Sarah said. It would have been a deliberate decision to modify my external presentation without changing my internal assessment of the situation. Captain Stevens looked up from his notes. That's actually quite sophisticated, maintaining operational awareness while projecting civilian normalcy. It's similar to what undercover officers do, Captain Webb added. They maintain their law enforcement training and judgment while presenting themselves as civilians. Admiral Richardson nodded thoughtfully. Torres, how would you feel about participating in the development of this training program? Your first-hand experience with the challenges involved would be invaluable in creating realistic and effective protocols. Sarah was surprised by the offer. I'd be honored to contribute, sir. What would that involvement look like? Initially, working with Captain Stevens and his team to document your experience and develop training scenarios based on your insights, Admiral Richardson explained. Eventually, you might be involved in testing and refining the protocols with other personnel. The program would be voluntary, Captain Stevens clarified. Not everyone would need this training, but it would be available for personnel whose assignments might require frequent civilian interaction. Admiral Richardson stood up, indicating that the meeting was concluding. Torres, I want to thank you for turning what could have been a security problem into a learning opportunity that will benefit our entire community. Sir, I was just doing my job, Sarah replied. Which is exactly why this worked out so well, Admiral Richardson said with a smile. You handled an unexpected situation with professionalism and good judgment, and now that experience is going to help us better prepare other people for similar challenges. As the meeting ended, Captain Stevens approached Sarah with additional questions about her willingness to participate in the training development process. Would you be available to work on this project over the next few months? Yes, sir, Sarah replied. What would be the timeline? We'd like to have preliminary protocols developed within 8 weeks, with initial testing to follow shortly after, Captain Stevens explained. Your input would be crucial during the development phase. After the officers had left, Commander Walsh offered her final thoughts on the situation. Torres, this has been an unusual case from start to finish, but it's ending better than anyone could have expected. It certainly wasn't what I anticipated when I went to the hospital with a dislocated shoulder, Sarah said. Sometimes the best outcomes come from unexpected situations, Commander Walsh replied. Your professionalism throughout this process has impressed everyone involved, and now you're going to help develop training that will benefit numerous other personnel. As Sarah left the conference room, she reflected on how dramatically her situation had changed. What had begun as a routine medical visit had evolved into a significant professional opportunity that would allow her to contribute to improving training programs for special operations personnel. The irony was that her hospital experience, which had initially seemed like a potential security problem, was now being viewed as a valuable learning opportunity that would enhance the capabilities of her entire community. More importantly, the incident had demonstrated the importance of adapting training programs to address the evolving challenges faced by military personnel who operated in both military and civilian environments. The lessons learned from her experience would help future operators navigate similar situations more effectively. That evening, Sarah called her teammate Mike Peterson to update him on the latest developments. The security review is complete, and they want me to help develop new training programs based on what happened at the hospital. 6 months after her unexpected hospital visit, Sarah Torres stood in front of a classroom filled with special operations personnel from multiple service branches. Her role had evolved from patient to program developer to instructor, and today marked the first official implementation of the civilian integration training program that had grown out of her medical experience. The objective of today's training, Sarah began, addressing the 36 operators seated before her, is to develop skills for blending effectively in civilian environments while maintaining operational awareness and security protocols. The program had exceeded everyone's expectations during its development phase. What had started as a simple response to Sarah's hospital incident had evolved into a comprehensive training curriculum that addressed dozens of scenarios where military personnel needed to interact naturally with civilian populations. Captain Stevens, who had become the program director, introduced Sarah to the class. Petty Officer Torres is here because she lived through the experience that identified gaps in our preparation for civilian interactions. Her insights have been invaluable in developing the protocols you'll be learning today. The students represented an impressive collection of expertise from Navy SEALs, Army Special Forces, Marine Force Reconnaissance, and Air Force Special Operations. All had extensive combat experience, but their reactions to the training concept had varied from enthusiastic support to skeptical resistance. Before we begin the practical exercises, Sarah continued, let's discuss why this training matters. How many of you have had civilian interactions where you felt you might have drawn unwanted attention to yourself? Nearly every hand in the room went up, and Sarah smiled. Good. That means you understand the problem we're trying to solve. Over the past 6 months, Sarah had worked with training specialists, psychologists, and experienced operators to develop scenarios that would test and improve civilian integration skills. The program included medical emergencies, routine business interactions, law enforcement encounters, and social situations. The key principle, Sarah explained, is conscious behavioral adaptation. You're not changing who you are or compromising your capabilities. You're learning to consciously modify your external presentation to match the expectations of civilian environments. The first exercise involved simulated medical scenarios. Students were divided into teams and assigned different injury types, then sent to a mock civilian hospital staffed by actors playing doctors and nurses. The goal was to receive appropriate medical care while avoiding behaviors that would mark them as military personnel. Sarah observed as the first team entered the simulated emergency room. The patient was a Navy SEAL named Rodriguez who was role-playing a broken arm from a bicycle accident. His initial approach was textbook military, clear, concise, and emotionally controlled. I have a fracture of the radius and ulna in my right forearm, Rodriguez reported to the triage nurse. The injury occurred approximately 45 minutes ago during recreational cycling. The actor playing the nurse looked surprised by the precise medical terminology and calm delivery. Sarah made notes about the interaction, identifying areas where Rodriguez could have presented more like a typical civilian patient. During the debrief session, Sarah worked with Rodriguez to develop alternative approaches. How might a regular person describe their injury? She asked. I broke my arm when I crashed my bike, Rodriguez replied, understanding the difference immediately. And how might they be feeling emotionally? Probably worried, maybe frustrated about missing work or other activities, Rodriguez said. Exactly. So your modified presentation might include those normal human concerns while still providing accurate medical information. The training scenarios became progressively more complex. Students practiced interactions with suspicious police officers, nosy neighbors, curious coworkers, and persistent reporters. Each scenario required different balancing acts between security requirements and civilian normalcy. One of the most challenging exercises involved social situations where students had to explain their obvious physical fitness and competence without revealing their military backgrounds. A Marine Force recon operator named William struggled with this scenario initially. When people ask about your workout routine or martial arts skills, Sarah coached, you need responses that satisfy curiosity without raising additional questions. Williams practiced describing himself as a fitness enthusiast and martial arts hobbyist rather than using language that suggested professional training. The subtle differences in word choice made significant impacts on how civilian actors responded to him. Dr. Marcus Webb, Sarah's original emergency room physician, had been invited to observe portions of the training program. His presence added authenticity to the medical scenarios and provided valuable feedback about which behaviors seemed most natural from a civilian medical perspective. The difference is remarkable, Dr. Webb commented during a break in the training. 6 months ago, Torres stood out dramatically because of her controlled responses to pain and stress. Today, I'm watching her teach others how to display more typical human reactions while still maintaining their professional competence. Nancy Peterson, the emergency room nurse who had treated Sarah, had also been invited to participate as an observer and consultant. It's fascinating to see this from the other side, she said. Now I understand why certain patients have seemed unusual over the years. They probably had similar backgrounds, but lacked this kind of training. The program's success had attracted attention from other agencies and organizations. CIA operatives, FBI agents, and federal marshals had requested similar training for their personnel who needed to maintain cover identities in civilian environments. Sarah found herself consulting on adaptations of the program for these different groups, each of which had unique requirements and challenges. The basic principles remained consistent, but the specific applications varied based on the missions and environments each group faced. One unexpected outcome of the training program was its impact on the personal lives of participants. Many operators reported that the skills they learned for blending in professionally also improved their interactions in genuinely civilian contexts, with family members, neighbors, and friends who were unaware of their military backgrounds. Learning to consciously moderate my responses has helped me connect better with my kids, one Army Special Forces operator told Sarah during a feedback session. I didn't realize how much my military bearing was affecting my civilian relationships. The program also addressed ethical considerations about deception and authenticity in civilian interactions. Students learned to distinguish between operational necessity and unnecessary dishonesty, developing judgment about when security requirements justified modified presentation and when normal transparency was appropriate. The goal is not to become a different person, Sarah emphasized during one session. The goal is to have conscious control over how you present yourself in different environments. Admiral Richardson visited the training program periodically to observe its progress and receive updates on its effectiveness. During one such visit, he pulled Sarah aside for a private conversation. Torres, this program has exceeded our most optimistic expectations, Admiral Richardson said. The feedback from participants has been overwhelmingly positive, and we're seeing measurable improvements in their ability to operate in civilian environments. Thank you, sir. It's been a privilege to work on developing something that helps our community, Sarah replied. I want you to know that your contribution has been noticed at the highest levels, Admiral Richardson continued. This program is being considered for expansion to all special operations units, and potentially to conventional forces as well. The success of the program had indeed attracted attention from senior military leadership. The chairman of the Joint Chiefs of Staff had received briefings about the training and its potential applications across the entire Defense Department. Sarah's own career had been transformed by the experience. She had been selected for promotion and offered opportunities to pursue advanced education in training development and organizational psychology. Her accidental discovery of training gaps had opened doors to professional development she had never previously considered. "The irony is not lost on me," Sarah told Captain Stevens during one of their program review meetings. "A routine training accident that required civilian medical care has become the foundation for a career specialization I never knew existed. Sometimes the most valuable contributions come from unexpected directions," Captain Stevens replied. "Your unique combination of operational experience and analytical ability has made you ideally suited for this kind of work." As the formal training session concluded, Sarah addressed the students one final time. "The skills you've practiced today are tools, not rules. Use them when they serve security requirements and mission success. Discard them when they're unnecessary or inappropriate. Remember that the goal is effectiveness, not deception for its own sake," Sarah continued. "You're learning to navigate civilian environments more smoothly, not to fundamentally change who you are or what you represent." The feedback from the inaugural class was overwhelmingly positive. Students appreciated the practical applicability of the training and the way it addressed real challenges they had encountered in their careers. "This training filled gaps I didn't even know I had," one Air Force Special Operations officer commented. "I've been interacting with civilians my entire career, but I never thought systematically about how to do it more effectively." After the students departed, Sarah remained in the classroom to prepare for the next iteration of the program. The curriculum would continue evolving based on feedback and lessons learned, but the core concepts had proven sound and valuable. Dr. Webb and Nancy Peterson approached her before leaving the facility. "We wanted to thank you for including us in this process," Dr. Webb said. "It's been educational to see how our civilian perspectives can contribute to military training." "Your input has been invaluable," Sarah replied. "Understanding how we appear to civilian observers is crucial for developing effective blending techniques." Nancy added, "It's amazing to think that your hospital visit 6 months ago led to all this. You've probably improved the safety and effectiveness of hundreds of military personnel." As evening approached, Sarah drove home reflecting on the unexpected trajectory her career had taken. The dislocated shoulder and fractured leg that had seemed like routine injuries had become the catalyst for professional opportunities she could never have anticipated. Her phone rang as she pulled into her driveway. It was Mike Peterson, calling with news about the team's most recent deployment. "How did the operation go?" Sarah asked. "Flawlessly," Mike replied. "And 3 of the team members used techniques from your civilian integration training during the mission. The skills transferred directly to operational effectiveness." This news was particularly satisfying for Sarah. The training program's ultimate value lay not in its classroom applications, but in its contribution to mission success and operator safety in the field. "That's exactly what we hoped would happen," Sarah said. "The training is only worthwhile if it helps people accomplish their real missions more effectively." "It definitely does," Mike confirmed. "You've created something that's making a real difference for our community." As Sarah settled in for the evening, she felt a deep satisfaction about the direction her career had taken. What had begun as an embarrassing security concern had evolved into a meaningful contribution to the capabilities and safety of special operations personnel. The hospital visit that had nearly compromised her cover had ultimately enhanced her value to the military community and opened new possibilities for professional growth and service. Sometimes the most important lessons came from the most unexpected sources, and sometimes the greatest opportunities emerged from apparent setbacks. Her story had become part of the training curriculum itself, an example of how professional military personnel could turn challenging situations into learning opportunities that benefited their entire community. It was a reminder that adaptability and positive attitude could transform even unwelcome surprises into valuable contributions to mission success. From potential security breach to curriculum development, Mike observed, "That's quite a turnaround. It turns out that my hospital behavior was too obviously military for civilian environments," Sarah explained. "They want to develop training to help people blend in better during routine civilian interactions." "Makes sense," Mike said. "We're all probably too obviously military when we're trying to be civilian." "That's exactly the problem they want to solve," Sarah agreed. "And apparently my experience is going to be the case study for figuring out how to fix it. A skill to seeming ordinary that we haven't mastered yet." The conversation reminded Sarah of the broader challenges faced by special operations personnel who moved between military and civilian environments. Their training prepared them for extraordinary situations, but it could also make them stand out in ordinary circumstances where blending in was equally important. As she settled in for the evening, Sarah made peace with the situation and focused on the positive aspects of the experience. She had received excellent medical care, her injuries were healing properly, and the security review would likely result in improved procedures for handling similar situations in the future. More importantly, she had learned valuable lessons about maintaining cover in civilian environments, lessons that would make her more effective in future operations where civilian interaction was required. The hospital visit that had started as a routine medical necessity had evolved into a significant learning experience that would ultimately benefit both her individual effectiveness and the broader capabilities of her unit. Mike nodded, understanding the importance of maintaining operational security even in routine situations. The CO wants a full debrief tomorrow about the obstacle course incident. He's concerned about the equipment failure. Good, Sarah said. That handhold should have been inspected more recently. Someone could have been seriously hurt. As they drove through the city streets towards Sarah's apartment, she reflected on her experience at the hospital. The medical staff had been professional and skilled, providing exactly the care she needed. Their curiosity about her background was natural and harmless, though it reminded her of the careful balance required to maintain her cover while living and working in the civilian world. For Nancy and Dr. Webb back at the hospital, Sarah Torres would remain a memorable patient, someone whose calm competence and unusual pain tolerance had marked her as distinctly different from their typical cases. They would occasionally wonder about her real background and what kind of training had produced such remarkable self-control under stress. Neither of them would have guessed that they had just treated a member of one of the most elite military units in the world, someone whose training and experience made her current injuries seem relatively minor compared to the challenges she faced regularly in her professional life. The evening shift continued at St. Mary's Hospital, bringing new patients with new stories and new challenges. But for the rest of that shift, Nancy and Dr. Webb found themselves occasionally thinking about the woman who had handled serious injuries with the calm professionalism of someone accustomed to much worse situations. In the world of emergency medicine, most patients were quickly forgotten once they left the hospital. Sarah Torres, however, had made an impression that would last much longer than her brief visit to their emergency room. Nancy watched in amazement as the procedure continued. In her 25 years of nursing, she had never seen anyone tolerate a shoulder reduction without pain medication and without showing any significant reaction. Most patients screamed, cried, or passed out from the pain. Dr. Webb completed the reduction successfully, and Sarah's shoulder settled back into its proper position with an audible pop. The relief was immediate and obvious as her arm returned to its normal position, and the severe pain subsided to a more manageable level. "How do you feel?" Dr. Webb asked, still clearly puzzled by Sarah's lack of reaction to the procedure. "Much better," Sarah replied, carefully moving her arm to test the range of motion. "Thank you." Dr. Webb and Nancy exchanged glances, both thinking the same thing, but neither voicing their thoughts. They had just witnessed something highly unusual, something that suggested this patient was not exactly what she appeared to be.